Real life.
Dr. Devasis, please proceed. You are muted.
A very good evening on behalf of EIZOC to all the audience members present today. I'd like to invite our office bearers president Dr. Jennifer Basaiwamat and our CSC Dr. Nitin Dhera. I'd like to welcome the mentor of this program since the beginning, Dr. Ajit Babu Majji, the chief coordinator who has depicted this program from the beginning, Dr. BNR Subuddhi, and the co-coordinator, Dr. Subhasaichi Patnaik. I also welcome our speaker for today evening, Dr. Manjushree Bhate, consultant neuro-ophthalmology from LV Prasad Eye Institute, Hyderabad. I welcome our moderator, the young and energetic Dr. Nilatparna Deuri. I welcome our ever-energetic group of panelists from the Eastern Zone, Dr. Anita Ambasta, Dr. Nazneen Nazam, Dr. Tirthajit Moitro, Dr. Shubhabrata Parida, Dr. Torun Panda, Dr. Rutyani Das. I welcome the young brigade of discussants today. We have eight of them today, and I welcome them to interact with the speaker and the moderator today. With that, I pass over to Dr. BNR Subuddhi to conduct the program.
Thank you, Dr. Devasis Das. Once again, I welcome our president, Dr. Jennifer Basaiwamat, to speak few words before we proceed further inside the program. Dr. Jennifer, madam.
Yes. Good evening, everyone. On behalf of EIZOC, it is my pleasure to welcome you all to the 39th session of our ophthalmology residence teaching series. Today, we focus on an important topic, cranial nerve palsy, involving the third, fourth, and sixth nerves, a subject that continues to challenge clinicians and remains vital in resident training. I extend my heartfelt thanks to our distinguished speaker, moderator, panelists, and discussants for giving their time and expertise. Your commitment is what makes this academic platform so meaningful. To all the residents and colleagues joining us, thank you for your enthusiasm and continuous support. I am confident that today's session will enrich our understanding and strengthen our clinical practice. Thank you. With that, I warmly invite our chief coordinator to take the program forward.
Thank you, madam. So let me start. Once again, I welcome you all to our ORTS program. This is 39th session, and today's speaker, Dr. Manjushree Bhate. As you know, cranial nerves, third, fourth, and sixth play a major role in ocular movements, not only from the neurological point of view, also from the stability point of view. So it's a very interesting subject, and today we have a very good speaker, Dr. Manjushree Bhate. Am I audible?
Yes.
Yeah.
Yes, sir, you are audible, sir.
Yes.
So I must thank our EIZOC team, President Dr. Jennifer Basaiwamat, Secretary Dr. Devasis Das, Dr. Chairman Scientific Committee Dr. Nitin Dhera, to continue this program relentlessly since a long time. So thank you very much, EIZOC team, for allowing me to continue this program. Definitely, mentor plays a major role in this program since last 3-4 years. He is mentoring so many programs, and I must thank him for the selection of speakers, selection of topic, etc. Thank you, Dr. Ajit Babu. This program is divided by both of us. Dr. Subhasaichi Patnaik always supports me for these programs, and we initiated the program in the COVID times, and we're continuing since last 4 years. Today's speaker, Dr. Manjushree Bhate, she is a consultant neuro-ophthalmology from LVPI, Hyderabad, and our moderator, Dr. Nilatparna Deuri, will introduce her. And Dr. Nilatparna are well known in the eastern sector, not only eastern region, also in all over India. She is one of the senior consultant at Arbor Vaiti Eye Hospital, Guwahati, Assam. And And today's panelist is already named by Dr. Devasis Das. Dr. Anita Ambastas, she's the professor at Indira Gandhi Institute of Medical Science, Bihar, Patna. And Dr. Najnin Najam, associate professor in ophthalmology at JIMS Medical College and Hospital, West Bengal. And Dr. Tirajit Maitra, phaco surgeon, medical retina specialist, Narayan Netrala Eye Hospital, Ranchi. And other three are Dr. Subhabata Parida, professor at Agadi Department, Syed Lakshman Medical College, Koraput. Dr. Tarun Panda, professor, RIU, Cuttack. And Dr. Rutayani Das, associate professor, MKC Medical College, Berhampur. These are our panelists, and we have 8 residents at discussants, and they are Dr. Sri Soumya Priyadarshini from MKC Medical College, Berhampur, Dr. Anshuman Singh from RIO IJMS, Patna, Dr. Lipika Mishra, SC Medical College, Cuttack, and Dr. Alok Sharma and Dr. Vivekanand Shah from SL Medical College, Koraput, Dr. Prachi from JP Rotary Eye Hospital, Cuttack, Dr. Shalu Bhagat from AIMS, Patna, and Dr. Priyanka Agarwal from Ruby Eye Hospital, Berhampur. So these are the discussants, and I request all of them to come with the video on and interact with our speaker today, Dr. Manjushri Bhate, and it's a very interesting subject, and I think we'll learn a lot from her. So with these few words, I welcome you once again, all the viewers, to this ophthalmic resident teaching program, popular program in the Eastern Zone. So it's now I hand over the mic to Dr. Nilutna to continue the program further. So it's over to you, Dr. Nilutna. To the speaker, please.
Thank you so much, sir. Thank you. Thank you, everyone. A warm welcome to all of you to this very interesting session by EIZOC today. So it gives me a great honor and pleasure to introduce a very great friend of mine, and also one of the most skilled neuro-ophthalmologist who is serving as a consultant at LV Prasad, Hyderabad. She has completed her long-term fellowship in pediatric ophthalmology and strabismus from Children's Hospital Westmead in Sydney, Australia, and then a short-term training from Akron Children's Hospital in USA. She brings along a vast and varied experience of working in different hospitals and healthcare centers like John Hunter and Children's Hospital, New South Wales, as a consultant pediatric ophthalmologist and strabismologist. As a part of our voluntary project, she was actively involved in setting up a pediatric eye care service in Myanmar, Southeast Asia. She's also a great teacher and has trained a local ophthalmologist there. Dr. Bhate is a member of several prestigious ophthalmological societies and has presented widely at various national and international conferences and published several articles in her name. Currently, she serves as a reviewer of many journals, including Asia Pacific Journal of Ophthalmology and Current Eye Research. And her main interest lies in pediatric cataract, complex strabismus, genetic eye disease, neuro-ophthalmology, of course, and retinopathy of prematurity. With these few words, I would like to welcome Dr. Manjushri Bhate to this session, and I request her to kindly share her screen and start with the presentation.
Thank you very much, Nilutparna. It's great to see you again. And I would like to thank the entire EIZOC president and all the members and Dr. Ajit Babu for having me. I'm very humbled. So I'm going to start by sharing my screen, and I believe we have 8 postgraduate students as well today. So it will be really nice if you interrupt me anytime, ask me questions, and if it is okay, I also ask you some questions.
That will be better, Manju. You should take the initiative so that.
Yeah, and it's okay even if you don't know the answers, because you are still learning. And it'll be okay if I can't answer everything as well. but that's on a lighter note. But definitely, if there's any query, please just raise your hand, chat box, or you can just interrupt me. So I'll start by sharing my screen now. So I thought I'm going to cover the 3rd, 4th, and 6th cranial nerve. And let's start with the 4th, because somehow 4th is the one which is relatively more complex when it comes to evaluating and assessing. So while we are all bright and alert, we'll start with the 4th cranial nerve. So can you all see my screen?
Yes.
Okay. So the 4th cranial nerve is the trochlear nerve, as we know. And the trochlear nerve is the longest course of the cranial nerve within the cranial nerves that supply the extraocular muscles. And also what's important is that it is cross innervation. So the nerve on the right side is going to supply the left eye, and the nerve on the left is going to go to the right. Okay, so these three little basic concepts are very important when we come to the applied anatomy as we go further. Okay, and which muscle does the trochlear nerve supply? Anyone can just shout out.
Superior
Superior
oblique.
oblique. Very good.
Superior oblique muscle.
Superior oblique muscle. Okay, so superior oblique muscle is one of the two oblique muscles in the eye, and it is the main intortor of the eye. It is going to cause intorsion. It's going to have the eye move inward. Okay, and it is also a depressor of the eye. So these are two important things to remember. We'll come to the anatomy of the trochlear nerve. We'll talk a little bit on the etiopathogenesis and the clinical features of a trochlear nerve palsy, approach to a case of suspected trochlear nerve palsy, and some investigations and management. So if any of this seems a little difficult or not understandable, as I said, just let me know. So what is special, as I said, about the trochlear nerve initially was that it is the only cranial nerve that exists at the dorsal aspect of the brainstem. Also, it has got the longest intracranial course. And why is this important? Is because anytime there is a patient who's got any sort of head injury or closed head trauma, or has a fall, or has bumped his head somewhere, and then he comes with a vertical double vision, then you need to keep a fourth nerve palsy on the top of your list. And why is it common? Is because of that long intracranial course of the nerve. Okay, and then the second, what I said was, as the left fourth nerve fascicle becomes the right fourth nerve, and it innervates the right superior oblique, and vice versa. So here you can see a simplified diagram of the anatomy of the trochlear nerve. So there is the trochlear nerve nucleus. From there you are seeing the fascicular part. You can see it crossover on the opposite side, and then it is going and passing through these various structures, important of which is the posterior cerebral artery, the superior cerebellar. Then it is going into the cavernous sinus, and that is where it is in close proximity with the other cranial nerves that innervate the eye muscles. And then it will go into the superior orbital fissure and finally pierce the superior oblique muscle. Okay, so the nucleus, it has a fascicle, it has the trunk, the cavernous portion, and the intraorbital portion. That is once it enters the orbit, and then it goes and innervates. So this is kind of just giving its correlation with the other structures that you see. Don't have to go into too much depth or detail. It's a little busy slide, but as I said, those important salient features are the ones that we mentioned at the beginning. And here, this, I'm sure most of you are familiar with this diagram. What is this diagram? It is a coronal section through the cavernous sinus. So it is telling us where is the fourth cranial nerve, where's the third, where's the sixth, all the structures that are in close proximity to that as well. Okay, and in close proximity to the internal carotid artery. So whenever you see multiple cranial nerves involved, or there is an ophthalmoplegia where you suspect both the third as well as the sixth, and sometimes if you are able to elicit the fourth nerve function, the fourth as well, you need to think of pathology where all these nerves are going to come together, which is near the cavernous sinus. Okay, so this is the anatomy as it enters into the orbit, and it supplies the superior oblique muscle. So that is the muscle right up the top over here. You can see it bending around the trochlea and inserting onto the posterior aspect of the superior part of the globe. Okay, so let's move on from the anatomy now. So we've covered quite a few of the details of anatomy that is required for you to know. Then what is the etiopathogenesis of that? As I said, very often it can be, so to begin with, it can be either congenital or acquired. And congenital can often be either associated with some amount of hypoplasia at the time of development of the fourth cranial nerve. and acquired, there are multiple causes. Okay. So when you look at a patient who has a fourth nerve palsy, as always with any patient in ophthalmology, the vision is most important. So both corrected and uncorrected visual acuity. Facial asymmetry is a very important clue of a congenital fourth nerve palsy, and that is, we'll come to it later. An abnormal head posture is one thing that they will adopt, and most often you will see it in an acquired patient, sometimes even in congenital, but especially in acquired patients where they will have a tilt of the head to one or the other side, depending on which side is involved. Or if it is bilateral, then they will have uh, they will have either a chin up position. So what is important here is that we need to understand that the abnormal head posture is there only because the patient is trying to fuse and trying to get rid of or alleviate the diplopia that he is experiencing. Then on ocular examination, so the initial part is the assessment, and then is the cover test and the ocular motility, that is checking the eye movements in 9 positions of gaze, both inversions and ductions. Especially in the fourth cranial nerve, we need to do a Parkes 3-step test, which we'll come to, and a double Maddox rod. And a double Maddox rod is mainly done to check for the degree of torsion. It is a subjective test. The objective test for torsion is anyone wants to answer in the chat box? So when I don't know if you all have seen a double Maddox rod test, but in that, when you put that red lens in front of the eyes, you're actually going to ask that patient to align the two lines, and this is done by turning the to some degrees, whether it is either inside or the way the patient would turn. And so that is more of a subjective test. An objective is, I don't know if anyone has written in the chat box, but it is a fundus evaluation by which we come to know the degree of encyclotorsion. And then we spoke of facial symmetry. So this is more characteristic of a congenital superior oblique palsy, in which there is shallowing of the midfacial region between the lateral canthus and the edge of the mouth. So there is a little picture that I will have. Okay, so here you can see 2 patients who are showing a facial asymmetry. Okay, sometimes the facial asymmetry can be because of a plagiocephaly as well. So you definitely need to rule out that. And here you can see there's a left hypertropia. Okay, that is in this case of left superior oblique palsy. So as I said, there is it can be indistinguishable from torticollis, where sometimes the patients may tend to hold their head towards one side, and at that time you need to definitely palpate the neck muscles and the sternocleidomastoid. Also, you need to distinguish from plagiocephaly. So these are all the differentials when you see facial asymmetry. Or sometimes in your exam, if someone asks you, oh, why do you think this facial asymmetry is because of a superior oblique palsy? So you can say that there are other reasons, but we need to do a 3-step test to find out. But definitely if there is a facial asymmetry, then a chance of a congenital superior oblique palsy is always there on our list. So these 2 pictures I showed you. Then is abdominal head posture, that is a compensatory head posture where the head tilt is away from the affected side. Okay, and a paradoxical head tilt is the one which is towards the affected side. And as I said before, there will be a bilateral acquired palsy where there can be superior oblique involvement, especially in a closed head trauma patient. It is often bilateral and they will have a chin down head posture. So what is important is a Parkes 3-step test, and sometimes examiners like to ask this question. It's like a very traditional question for exams. So in that, you're looking at the eye that is hypertropic. Now suppose in this little animation, you are seeing the right hypertropia, if you can appreciate the right hypertropia. So the right hypertropia can be because of overaction of the elevators of the right eye, or it can be because of the depressors of the left eye. Okay, so these are the 4 muscles where you look at when you look at a patient in primary position. who has got a hypertropia of one eye relative to the other. So this is often depicted as a right/left, or a right on left is what it is called as. Then you check the side gazes, whether it is worse on left gaze or it is worse on right gaze. So in this case, you come to know which of the muscles are going to be involved. So now see what's happening. It is worse on the left gaze. Okay. So when it is worse on the left gaze, you are eliminating two muscles anyway already. So here, because of the right superior oblique under action, or the right superior oblique which is paralyzed, so to say, there is unopposed action of the inferior oblique, and the inferior oblique's main function is elevation and adduction. So that elevation and adduction is more pronounced, and you are seeing a worsening or an increase of the right hypertropia on left gaze. Okay, and then you do a tilt. So the tilt is the last of the third step, and if it worsens on right tilt, that is the hypertropia increases, then you know that you're dealing with the right superior oblique palsy. So there's also, I'm not going to go into these details. This is a little bit for our fellows who are actually doing pediatric ophthalmology to look out for what happens in up and down or in sleeping position. This is the Maddox rod test that I told you, where we put these two little red lenses in front of the eye, which has got vertical lines, and then you see a horizontal line image of the two eyes, which you need to align by turning that lens and finding out the degree of torsion. So in these animations, we were talking about a right superior oblique palsy, where the right eye is higher than the left eye. So there is a right hypertropia, which is worse on left gaze and which is worse on right head tilt. It is also called as right, left, right. So if any of you were in school and doing marching in school, you remember when you do march pass, you say right, left, right. So remember it in that way if that helps. Okay. Then is the supine and upright test. This is another test to differentiate mainly between skew deviations and a cyclovertical muscle palsy. So when there is an increase in vertical deviation from an upright to a supine position. Then we spoke of the torsion and the degree of torsion that we see on fundus examination in cases of acute superior oblique palsy. And you can actually grade the amount of torsion as well. And more the degree of torsion, and especially if you're seeing it in both eyes, you do know that you're dealing with a bilateral case. Okay, so the other thing what you need to do is a patient who's got a superior oblique palsy. Over time, if that right eye is always hypertrophic, then there is increased innervation going into that muscles, and those muscles will go into contracture. So the right superior rectus over time is going to go into contracture. So this 3-step test and all this is fine in a patient who's got an acute superior oblique palsy. But in a chronic case, there is something called as a spread of comitance, wherein it doesn't always follow these rules. And then you have to look at all the other cues that you see in patients who have a suspected superior oblique palsy. So there can be tightness of the superior rectus muscle. If the patient is fixing with the palsied eye, there can be a contracture of the inferior rectus of the contralateral eye. There can be a inferior oblique overaction, as we anyway spoke of. So you have to look at all these additional telltale signs. So this is a child, you can see over here that she's got a left eye, the inferior oblique is really overacting. If you look at the top right position over here, there is over elevation in adduction of that left eye. Okay, and if you look at the bottom picture over here, what do you see? The bottom right picture, or the left of the screen. So you see that there is underaction of the superior oblique. That is, you can see that eye which is at a much higher level as compared to the left. So anyway, you know that you are, based on the ocular motility, that you're probably dealing with a weaker muscle, or that is a weaker superior oblique, which could be either paretic or paralyzed. Then another important thing is to remember that the superior oblique is an intortor. So torsion is very important. And in acquired cases, torsional diplopia is something which often happens. And this was one thing which was there in a patient who fell off his bike, and he was a farmer. He had to look down all the time. He needed his down gaze, and that is where he had all this double vision. As you can see over here, on the down and right, he had a right hypotropia. On down and left, he had a left hypotropia, and he had a significant torsion, and he had a bilateral trochlear nerve paralyzed and bilateral superior oblique involvement, because of which it was difficult for him to do his routine work, though he was orthotropic, just looking straight ahead. So this is his relevant gazes. As you can see, there's under action of that superior oblique muscle while looking down and in both the eyes. The other thing, at least when we were medical students, what was taught is that how do you remember the action of the superior oblique? Or if somebody asks you, how do you elicit the action of the superior oblique? You're asking the patient to look down and in. You remember it is the muscle used for copying. So when you're copying from your neighbor's paper, what do? You look down and in towards whichever side. So remember that way as an action of the superior oblique. And this is just a little quirky tip. So if we come back to the patient, as you can see over here, there is significant torsion. The macula is looking much displaced as compared to the position when we look at the disc and the macula. Okay, and on a double Maddox rod, this is any torsion of about more than 8-9, you think probably this is a bilateral involvement. Okay, so what are the options? In any case of palsy, always the option starts conservatively. So either you can do nothing, wait and watch and see if things improve on its own. We can ask the patient to put a patch on one eye if the double vision is bothersome. Depending upon the etiology of the palsy, which we'll go more into in third and sixth, you can always think of treating any ischemic risk factors. Then prisms can be given, surgery can be done, and surgical option in case of torsional diplopia is a Harada-Ito procedure, which was performed in this patient where the anterior fibers of the superior oblique muscle, as you can see over here, which are on this small little hook, they are moved closer to the upper border of the lateral rectus muscle to correct the torsion. So these are the torsional fibers. So the anterior fibers are the torsional fibers and the posterior fibers are the depressors of the eye. And this patient did well post-operatively. So with this, I'm just going to stop. If you've got some overview of the superior oblique or the fourth nerve, before we move on, if there's any question that anyone has. Okay, so I think everything was very clear there.
Oh, they are hesitant to ask the questions.
I don't think
Probably
you need to be hesitant.
you
Don't.
have the names, I think, Manju, in this thing flyer.
Yeah.
So you can select 1 or 2 or 3 people who answer
Anyone?
the questions.
Okay.
Anyone is no one.
Anyone is no one. Okay, this is going to be very hard for me to also know who is who. Nazneen? Who's Nazneen?
Nazneen is, I think.
She's the panelist.
She's faculty.
That's why I said, because I don't know all of them, no, so it's a little difficult for me to just.
Soumya is there.
Soumya.
Yeah, Dr. Soumya.
Yeah. See the discussion. Shalo is there, Soumya is there, Vivekanand, Sakhi, hello.
Okay, we'll
Yeah.
start with Soumya and Shalu.
Yeah.
Do you have any questions, specific question for fourth nerve, where you understood everything about fourth nerve palsy? I started with fourth because that is a relatively tougher. Often they're all DNB students or what?
They are all postgraduates. Postgraduates means
Postgraduates.
MS ophthalmology.
MS. So many a times it will often be a sixth or a third cranial nerve, but it could also be it could be a fourth, or your viva could go on to that, or something in the written exam. Anything that you want to add, Dr. Nilutparna?
No, it has been very clearly explained, ma'am. I think for the residence purpose, this much is, I think, enough.
Enough, okay.
Yeah.
Sure. So let's do one thing. maybe I'll go through.
Okay.
Sorry,
Yeah, we'll go to the second one. So
we'll go through the third nerve then.
yeah.
Yeah.
Yeah, we can move on to the third.
Okay.
Yeah.
Just a minute to again share screen. No? Okay, can you see the screen?
Yes. Yes. Yes.
Okay, so I'm going back to slideshow and we'll go to evaluation of third nerve palsy. Now, I'm not going to go through much of the details of anatomy, it's all there in your textbooks. But what's important to know is that it arises from two nuclei, the oculomotor and the accessory nucleus, that is the Edinger-Westphal nucleus. Okay, and the third nerve nucleus is located in the midbrain. So very often, sometimes if there is a nuclear component of the nerve, there also will be other involvement of certain, which we call as syndromes, which come in association with the third nerve. But the third nerve is a nerve which will start at the nucleus, then it will have a fasciculus, then it will have an intracranial course, then it will have an intracavernous course, then it will have an orbital course. So along that course where it is traveling to reach up to all its muscles, there can be several places where there can be a site of insult to that third nerve. And very often, if it is a congenital third nerve, then that child is going to be born with some degree of ptosis and limitation of eye movements. So which is the muscles that the third nerve innervates? Soumya, now that I know your name. Which muscles does the third cranial nerve innervate? Am I audible?
Yeah. You are audible.
Okay. So remember that the fourth nerve we spoke of, it innervates the superior oblique. The sixth nerve innervates the lateral rectus. So all the other muscles are innervated by the third cranial nerve. Okay, when the third cranial nerve enters inside the orbit, it divides into the superior and the inferior branches. And the superior branches will supply the levator palpebrae superioris and the superior rectus muscle, whereas the inferior will innervate the inferior rectus oblique, that is the inferior oblique, and the medial rectus muscle. So it's very simple if you know which are the muscles in the eye, that except those two muscles, the rest all are by the third nerve. Okay, so we spoke of the location of the nucleus, which is in the midbrain, and some of the syndromes that can be associated, or when you look at bilateral versus unilateral third nerve. Then is the fascicular part of the third nerve, and these syndromes which you may have remember in your medical college days, that is the Weber's, and remember that it can affect or it can cause hemiparesis of the extremity. So if at all you see a patient, the application is only that okay, you're doing ophthalmology or you're giving ophthalmology exams, but if you have a patient in front of you who looks like he's having a third nerve palsy with some difficulty of walking, then you need to think or need to be able to localize grossly where could be the site of the lesion. And that's when the neuroimaging will then confirm, but initially clinically you need to be able to localize that. So Weber's, then this is the Benedict syndrome. And before we come to cases, something important is to know the etiologies when we talk of third nerve palsies. So it can be either a complete or an incomplete third nerve palsy. When we look at complete third nerve palsy in an elderly patient, you're most likely thinking of a ischemia to that is ischemia because to the blood supply to the third nerve. And commonly causes of ischemia will be if there is some metabolic derangement. So either the patient has got diabetes or lipid derangement or hypertensive. So any of those, then that is the ischemic cause. When you look at relatively younger patients who have got either a complete or an incomplete third nerve, then think of more of inflammatory causes or traumatic causes. Okay, so when you think of etiologies also, if you see a 70-year-old patient in front of you, don't say, oh, this can be inflammation, because that is where your most likely or least likely diagnosis plays a part. So when we think of etiology of any of these cranial nerves, be it third, fourth, or sixth, you always think of congenital and acquired. And then when it is acquired, it could be either inflammatory or it could be an infective pathology, which is unlikely in cranial nerves. And it could either be traumatic, and in elderly age group, look at ischemia as a important cause. So this comes to the etiopathogenesis, which is grossly important for any of these. So this is a patient, as you can see her right eye. So you can't see much of ptosis, but her right eye is exotropic. So it is out and down. So any patient with a down and out eye position in primary, you then assess the eye motility and see that there is some amount of limitation of adduction of that right eye. So if you look at the central row, there is some amount of limitation of adduction which you are able to see. Okay, so in this case, it is an incomplete third nerve palsy, and you can see on the DWI there is this area that is brightening up over here. So that is when you think of an incomplete third nerve palsy. And most often, any incomplete third nerve palsy, what is the most important sign that you look for is the pupil. So if there is a pupil involvement in any patient who's got an incomplete third nerve palsy, neuroimaging is a must, and neuroimaging is an urgency, and it is a life-threatening condition. Why? Why am I saying that? Anyone wants to answer that question?
Ma'am, it could be associated with an aneurysm, a PC aneurysm.
Very good, excellent. So it could be associated with the posterior communicating artery aneurysm, and it is life-threatening only because that aneurysm can bleed anytime and the patient can die. So if you are diagnosing a patient with a incomplete pupil involving third nerve palsy, or even a complete pupil involving third nerve palsy in a relatively young patient, definitely urgent neuroimaging. And when you say neuroimaging, what do you order? Or what do you ask for? Will it be picked up on an MRI?
Angio.
Sorry?
MRI angio?
Yeah, MRI angio or a CT angio. Even
CT.
a CT angio can pick up the smallest size aneurysms. MRI angio, they say, requires a slightly larger, maybe about 6 millimeters. But nowadays, I think with the current newer machines, either CT or MRI angio would be equally good. So even if you take home one important point from third nerve palsy, is that you never miss an incomplete third nerve palsy, never miss a pupil involving third nerve palsy, even if sometimes the pupil can be the first sign of a third nerve palsy. So some diplopia, a little bit of limitation of eye movements with pupil involvement, definitely do a neuroimaging and rule out a PC aneurysm. So here again, if you see, this patient doesn't have much of ptosis, actually. He does have some limitation of adduction of that right eye, and not such a good case. Let's go to next one. So we spoke of the PC aneurysms over here. So this is all compressive, painful, and pupillary involvement. So this is another patient who came with a left eye ptosis since 1 month, which was good vision. The ISPAC test was negative. So that is one of the common differentials that you need to consider over here. And here you can see that pupil involvement. Okay, in this near complete ptosis with pupil involvement and motility limitation. So there is absolutely no adduction of -4. Elevation is limited in that left eye. If you look at the photos up the top, she cannot elevate that left eye, nor can she depress it very well. Okay, and this pupil is very grossly mid-dilated, which you can see over here. And in this MR angio, you can see the arrow pointing out to that aneurysm, that little outpouching, which you can see. Okay, so this is another patient who had a right eye poor vision, drooping, and there is definitely uncontrolled diabetes with HbA1c of 8.8. Okay, so in this case, you would think more in terms of a ischemic third nerve palsy, and these usually do resolve over time. So again, as we spoke of management options, always start conservatively. After coming to an etiological diagnosis of the palsy, then first think of correcting the diplopia or alleviating the diplopia, not correcting, but with the help of patching, and then think of prisms, and surgery becomes an option much later after you've given it enough time to resolve on its own. Okay, so
And
same.
if it is aneurysm is there, then probably neurovascular
Yeah.
interventions are
No,
better.
aneurysm after this is after ruling out the etiologies.
Yeah,
So once you have come to an etiological diagnosis and you're thinking, oh, this is an ischemic, and you're going to now wait and watch and see how much it improves on its own, these would be the management options. But if
How long should we wait? Months?
for ischemia,
Yeah, for ischemia, you have ruled out all the other neurological.
so ischemic palsies will often on their own resolve in a couple of months, 2 to 3 months. Very rarely will they not resolve. Some amount of ptosis and a little bit of exotropia will remain, which covers with prisms. Very less likely that they are the ones who need surgical correction.
Yeah.
The ones who are inflammatory third nerves, like I've seen the third nerve where the entire nerve is lit up like a Christmas tree decoration or something. So those are the ones where we need to give steroids, either IV or oral steroids. And of course, the ones with aneurysms are straight away referred to neurosurgery. So it depends on what is the etiology, but just calling it a third nerve is not enough. We need to call it a third nerve because of whatever etiology, and also define whether it is complete, incomplete, pupil sparing, or pupil involving. So that would be a complete diagnosis in third nerve. So that is one thing which is very important to be able to understand. Any questions?
Ma'am, is it required to do neuroimaging in all cases of third nerve palsy?
Yeah, so that's a very good question. So by definition or by textbook, if it is a complete third nerve palsy, and it is not pupil involving, and it is in an elderly patient, then you know most likely, and there is some metabolic derangement, either lipids or sugars are high, then you know this is the cause of the third nerve. And in those cases, you can avoid doing neuroimaging, or definitely not urgent neuroimaging. If at all you call the patient in 3 to 4 weeks and they've not improved in any way, the ptosis is still the same, then neuroimage. Practically speaking, when we are actually practicing as clinicians, the threshold to neuroimage is quite less. So we tend to neuroimage much more, but these are the patients who I would wait and not urgently neuroimage. But anything other than that, I would do an MR angio along with an MRA, especially if it's a pupil involving, be it complete, incomplete, whatever age group. I hope this answers your question.
Thank you, ma'am.
Yeah, so the cavernous part, we spoke of all these things. And I'll go on to the sixth nerve if that's okay. There's nothing much. So this was a, I mean, I've got like many cases, but
can we just shine a light on maybe aberrant regeneration of the third?
Yeah, perfect. So aberrant regeneration will often be seen in patients who have old trauma or long-standing trauma and a traumatic third nerve palsy. And the aberrant regeneration signs are seen both in the eyelids as well as in the pupils. So sometimes there will be pupillary dilatation on adduction. Sometimes there can be a synergistic movement or a little bit of eyelid retraction on eye movements, especially more on adduction. So this is when the after trauma, when there is some amount of recovery of the nerve function that is seen. So what's important to know, in traumatic, many a times they do land up needing surgical correction, and often it's good to advise the patient that you should have surgery on both the eyes, especially the good eye, because some amount of aberrant regeneration can happen on the affected side. So other than that, I think for your level, aberrant regeneration is mainly eliciting and to be able to evaluate and to be able to diagnose that this is a third nerve palsy with aberrant regeneration is most important.
Yeah, I think, yeah, that is important. And I think in aberrant regeneration is the only condition where we operate on the good eye in order to alleviate the ptosis of the bad eye, like involved eye. This one, and maybe sometimes if, as you have already said, that trochlear can be involved with third nerve, then how are we going to elicit the trochlear function?
Yes, that's a great question.
Or a PG
So
resident.
anyone wants to try and attempt that answer. So how do you come to know there is a fourth nerve and a third nerve palsy if it's a combined palsy? So how do you elicit for a fourth nerve function in a patient? Because you cannot ask that patient to adduct the eye. The patient is not going to be able to adduct an eye if a third nerve is involved. So you're not going to be easily able to look at the down and in position. So in that case, there are two ways. One is looking at on a slit lamp, looking at a conjunctival vessel and looking at the nasalization of a conjunctival vessel when you're attempting to ask that eye to look in the direction of action of the superior oblique muscle. Okay, so where that conjunctival vessel will rotate inwards. That is one. Secondly, without a slit lamp, you have to bring that eye in a position where the eye is a maximal intorter. Okay, so the maximal intorter is actually, I mean, if you look at the degrees, they say 66 degrees, but it's very hard to elicit 66 degrees. So you ask that patient to slightly abduct the eye. So when you slightly abduct the eye and then you move your target right from top to bottom. And when you move that target from top to bottom, you will see that eye intort. You'll actually see that eye physically intort without looking at a slit lamp. So these are two important signs because that in that case is the only way you're going to be able to elicit a superior oblique function and then see that the fourth nerve is not involved. If you're not able to elicit in any of these, then probably the fourth nerve may also be involved in these cases. I don't know if that answers your questions, but try and actually next time you see a patient, try and do it so it will just stick in a little better.
Would you like to take any other questions, or I think that will suffice?
Questions are there, she will take.
Yeah. I mean,
the
PG students, if they want to ask anything, like in third nerve, there are a lot of things actually. As Dr.
Third nerve is
Manju,
a very big topic. It's like a topic for 1 hour itself.
Yeah, it's like involvement of every single muscle will also be there. So like superior rectus bilateral if involvement or bilateral congenital third nerve, that is also an issue. So many things are there, but for the students' sake, I think this much is okay. Then we can move on to the sixth nerve probably.
Okay. So, I mean, even if some questions come on later, just put them in the chat box, please.
Chat box, yeah. Okay.
So we'll move on to the sixth nerve. So before I move on to the sixth nerve, now I'm only going to ask 2-3 questions. Okay. So tell me the muscle that the sixth nerve innervates. Just quickly answer these questions.
Lateral rectus.
Lateral rectus. Okay. What is the function of the lateral rectus muscle?
Abduction.
Abduction. What are the causes of sixth nerve palsy? Why does it happen?
Madam, due to trauma or
Okay,
increased
so we spoke
intracranial
about
pressure.
when anyone asks you causes, you start with it could be congenital or acquired. In acquired, it could be 1, 2, 3, 4. Tell me 1, 2, 3, 4. One is trauma. What else?
Raised cranial pressure.
Yes, raised intracranial pressure. Very good.
Trauma, diabetes, hypertension.
Yeah, so
Infections.
Ischemia. Very good. Okay, so when you see a patient of sixth nerve palsy, when you're actually seeing a patient, imagine sitting in front of you, what will be the eye position of the involved eye? Will the eye be looking straight, in, out, esotropic, exotropic?
Esotropic.
Esotropic. And what will be the motility of the patient?
Limitation to abduction.
So limitation of abduction. straight abduction and abduction in elevation and abduction in depression. And also it will be same on versions and ductions. What else is going to, so suppose you see a patient with limitation of abduction, how will you distinguish whether this is due to a paralysis or paralytic pathology or a restrictive pathology? Restrictive means that the eye is not able to move due to some other reason. Suppose there was a fracture and there is some amount of muscle entrapment or some amount of muscle damage, and that eye is not able to abduct. How will you know whether it is a paralytic cause, or what else can you do?
Force duction test.
Force duction test.
Before that, something that you can do in the office. Have you heard of saccades? So how do you elicit saccades, and what is the difference in a 6-nerve palsy? How are the saccades? So saccades are slow. So slow. So you are asked, when you're checking horizontal saccades, you're actually asking the patient to move right and left. Okay. And when you're trying to, suppose the patient has got a right 6 nerve and he's trying to get that eye into a right abducted position, that I will try and slowly reach up to the and then stop. Okay, it's not like a abrupt stop. So there are slow saccades. So that is one thing which always differentiates between a restrictive and a paralytic pathology. Okay. Other thing to remember in a 6 nerve is when you look at the deviation. The deviation is always more in distance than near. So the esotropia that you measure is always going to be more in distance and near, as opposed to a restrictive pathology where the distance and near deviation is going to be the same. Okay, so these are just some finer points, but it's definitely good to know that, or if you add these will know that you actually worked in a clinic, you've actually seen patients of 6 nerve. I just hope that makes some sense. Okay. So we'll go through some cases maybe of 6 nerve. So this is a patient who is young and came with inward deviation of the left eye, double vision, and was hypertensive, was admitted in ICU and had a cerebral venous sinus thrombosis. And this is his esotropia. It is small. It is 20. And you can see that there is limitation of abduction of that left eye. Okay, where you can see it's written -3, and also of the right eye. So it's written -3 on both the sides. Okay, so there is some limitation. And this is the fundus picture. So what are you thinking as the etiology of the 6? There is a 6 nerve palsy because there is limitation of movement in abduction. This is the fundus. So 6 nerve is one nerve where I would always check at least the posterior pole, if not the entire retina. From an etiological point of view. Okay. So what could be the etiology in this case?
Hypertension.
Hypertension. I'm not talking about just the fundus. I'm trying to put it together. So think of raised intracranial pressure or a false localizing sign. Okay. So in cases where there is disc edema. So these are important things. So you do a CSF opening pressure, making sure that there is no intracranial space occupying lesion. And if there is a raised CSF opening pressure, then you know that the cause of the 6th nerve is not actually the 6th nerve that is paralyzed, but it is a false localizing sign because of the raised intracranial pressure, where it is causing the signs of 6th nerve palsy, and it will resolve once you treat the cause. So knowing a etiological diagnosis, as we spoke before, of any cranial nerve palsy is very important, because then you have to treat the cause. So in this case, these are symptomatic measures of monocular patching and trying to buy time as it resolves on its own. Then let's see what is another case. So this is a slightly older female, 50-year-old female, who had difficulty of outward movement of the left eye. And she had history of road traffic accident 3 months ago. And So this is her eyes. So she's got a very large angle esotropia, and that left eye abduction, there's hardly any abduction. It's -6, and she's adopting a head posture. As I spoke right in the first presentation of fourth nerve, that the head posture is mainly there because the patient is fusing and they're trying to get rid of the double vision, which is why they hold their face or their head in a particular fashion. Okay, so we've done, we've concluded that this patient has a 6th nerve palsy. We know that there was a history of trauma, so we give it some time to recover on its own. But when there is such a large esotropia and there is an abnormal head posture, there is always a risk that that eye that has gone inside, or the esotropic eye, that medial rectus is going to go into contracture. So we don't want that to happen. So this is one case where you have to think of giving a botulinum toxin into the medial rectus. That serves two purposes. It does not allow that muscle to go into contracture. It reduces, I wouldn't say that it will definitely get rid of, but it definitely significantly will reduce the double vision and the abnormal head posture. So this is an interim treatment. In any case of trauma, we usually wait for 6 months before any definitive surgical treatment to give it time to recover on its own. But in the interim period, these are the management options that you can consider, okay, other than just putting a patch on that eye. So that was a different case of 6th nerve who underwent Botox. And there we can see that esotropia is almost halved. And later on, the patient underwent a strabismus surgery in the form of, so these are also maybe questions that could be asked. So what surgery will you do? So anytime you know that that eye is esotropic, you will weaken the muscle that is pulling that eye in. So you will recess the medial rectus, and only recessing may not be sufficient. So there are other surgical procedures that will counterbalance. So like transposition, half tendon, full tendon, nishidas, there are different options. 6th nerve is not like there is one blanket answer to it, but definitely weakening the muscle that is pulling the eye in is the first. And then for the antagonist, you can do a transposition, or if there is some partial recovery of the 6th nerve, then even a resection. So these are important surgical principles, I would say, not the details. Okay, so after surgery also from 90, she's now come to 30. So finally she had 2 surgeries and she's better. Okay. So I have one more. Okay, any questions? No questions.
Ma'am, do we give botulinum toxin before operating?
Yes. So botulinum is in the interim period, as I said to you, when you're waiting for you're going to buy time, because you cannot straight away treat a traumatic patient. You have to give it time to recover, and the ideal time is a minimum period of 6 months. They say 6 to 9, but 6. So botulinum is something given in the acute phase, not when the muscle has become tight and fibrotic. It's not going to work.
And can we give it more than once?
Yes.
And post-surgery also, we can?
Yes.
Okay.
You can give any number of times. Every time you give a Botox, you need to definitely tell the patient that this is temporary. It can last for 2 to 3 months. There can sometimes be some drooping of the eyelid, which can stay for a week or 2, especially if that Botox dissipates and goes to the LPS muscle. But you can definitely give it 1 to 2 times. I mean, most people would not give more than 2 or 3 times. I don't know what you do, Nilutparna, but I've not given more than twice. I don't think so.
No, not
Ma'am,
much.
can Botox cause other nerve palsy while giving?
So you're giving the Botox into the muscle. You're actually giving it into the muscle belly. Okay. So you're giving it close to where the muscle is inserted. It's not just randomly going anywhere. So ideally, it should not affect anything more than the muscle that you're giving it into. But sometimes that little bit of Botox can dissipate and go to the LPS, especially if the patient is in a prone position, and then you're going to make the patient sit up. So sometimes a little bit of ptosis can happen, but other than that, nothing. unless you just too aggressive and push it here and there. But by and large, it is, if done correctly, it is pretty benign as injection.
Yeah, like holding the muscle belly correctly at the position, just like you do for superior rectus brittle suture, you hold
Yes,
the
you can just hold it with that brittle forceps. That's a great forceps to pinch the muscle and just give it into the muscle belly.
Yeah, so sometimes they say like, like you go through the conjunctiva or maybe you separate and you go into the muscle belly. So those things is what Dr. Manju is saying, that if it might dissipate and cause some amount of ptosis post-injection, but then it will wear off with time. That you have to counsel the parents before the injection, if it is a child, or else like for
Yeah,
any
or the
Botox,
adult.
for any Botox
Or you
injection.
definitely call the patient in 2 weeks to your clinic to see what is happening to
Yes,
how is
yes.
the eye position, how is the eyelid position. I
think that was quite an extensive
Yeah, I think we've been talking more than 1 hour.
Yeah,
But,
it was quite engrossing and very elaborate, actually, starting from the anatomy, basic anatomy to.
I
and
wasn't sure exactly
detail.
how much and how, because it's something which you can just go on.
Yeah.
So I don't know. I hope it's covered essential things at least.
Yes, yes. Since it's a basic residence teaching program, the basics has been covered very well in this. Like as you said, we can go on with it just with one cranial nerve only.
Yes.
The entire session, but covered very nicely. So, Buddhi sir, if you would like to say something to the other discussions.
Let it be by the panelists. There are 4 panelists are there. You can ask them their
Yeah, and
comments.
I would request a panelist if they would want to give their own inputs or they would wish to know something more.
Yeah, good evening, madam. I want to just ask, can you explain the saccadic thing once again?
Yes, sure. So whenever we are testing for saccades is what they, in our saccadic system, we have saccades where we have either a saccade or a slow pursuit movements. Saccades is where there are abrupt movements. So you're asking, I don't know if you can see my fingers. If you're
Yes,
holding
sir.
up fingers, you're asking them to do brisk movement from one to the other. Okay.
Yeah.
And
Yes,
then
sir.
when they are doing this kind of brisk movement, you don't hold them too far away. You just hold them at a fairly reasonable distance. And that's when you closely look at the eye that is paralytic. And if you just see slowly it's reaching its target or it's reaching its finger just towards the end, that is the slow saccades that you see in paralytic cases.
Okay. And another thing, it is there is 2 procedures, Nishida and Jensen's procedures.
Yes.
So in case, according to case, you vary with the procedure, or you go for every case you could go for prefer Nishida procedure over Jensen procedure.
Yeah, so that's also a really good question, because see, the thing is that when there are so many procedures, this is what my mentor used to say from Australia, that when there are so many procedures for one particular condition, that means that none of the procedures are perfect or none
Yes.
of them work particularly better. Okay, so it can be individual. If the deviation is not too much, or if you're doing 3 muscles at one time, like you're going to recess the medial rectus and you want to get some abducting force by transposing, then instead of doing 3 muscles and risking anterior segment ischemia, it's safer to do a Nishida procedure or do a partial vertical rectus transposition.
Yes. Another thing, in fourth nerve palsy, what is the importance of the traction test? They are dividing in book, they are dividing this traction test, and according to that, they prefer the surgical procedure, which is better. So, what is your opinion, ma'am?
So basically, a traction test, you would do it more in case of congenital fourth nerve palsies, and in that it's mainly done to see how lax is that muscle and whether you need to do any tucking of that muscle, or whether a tuck of the superior oblique muscle is required or not. So it's not so much for acquired cases, but it is more for the congenital cases.
Yes, ma'am. Thank you.
Ajit sir, would you like to add something here?
I think, except for initial anatomy, probably you can highlight which are the nerves which are very proximal to each other, so that the combined involvements can happen.
She had given a cavernous sinus one photograph,
Yeah,
coronal section. Yeah.
those are important for the residents.
Yes, sir.
Yes.
For us, not so important, but for the exam point of view, it is very, very essential.
Yeah, so anytime there is a multiple cranial nerve involvement, definitely the site of pathology is a cavernous sinus for sure. If you see, this is more applicable for third and sixth. If you see a third and sixth, so when there is external ophthalmoplegia without pupil involvement, and if there is pupil involvement or not. So most of the time, it is either the orbital apex or the cavernous sinus that you're dealing with. If particularly if the vision is fairly not involved, I would say that we look for pathology in the cavernous sinus than the orbital apex. Orbital apex, the patients will have ophthalmoplegia. They will definitely have significant reduced vision, close to counting fingers or light perception. And often there is an inflammatory pathology in most of the cases that we see in our population here. Or even some infective like tuberculosis, that's also a really important cause. So both infective, inflammatory, again, you go through the surgical sieve to sort of investigate for the cause.
So in multiple cranial palsy, ma'am, the pupillary reaction can help in localizing the site of the...
It can help to some degree, but it definitely, regardless of that, it needs a neuroimaging.
It needs a neuroimaging. Yes.
Ma'am, how much this pupil involvement is reliable in as an etiological cause for the in third nerve palsy as microvascular or aneurysmal, as we are also dependable on this for the neuro imaging like CT angio in practical OPD?
Yeah, so in practical OPD, if there is a pupil involving, you should definitely rule out a compressive etiology because the pupillary fibers are situated on the outer part of the nerve. So any compressive etiology definitely needs to be ruled out. And as I said, those are the cases where you should neuroimage, not just with an MRI, but also with an MR angio. And having said that, many a times they will not come back with a compressive, not all of them will come back to you saying, oh, we found an aneurysm. Many a times they will not find an aneurysm in practical purposes. But still, you don't want to miss that, even that 0.1% patient, and be responsible for the death of that patient for sure.
Yes, ma'am.
I think time for us to, if there are no other questions, I think we will call it.
Okay.
One question from my side.
Okay.
Dr. Manjushree, lot of diabetic patients, they come with sixth nerve palsy.
Yes.
The common palsy diabetic patients is sixth nerve only. And how do you manage these patients? By just simply by waiting?
No, by controlling their diabetes, you definitely have to send them to the physician and get them on.
Even
yeah.
controlled diabetes also, they sometimes get the diabetes and sixth nerve palsy. Very common you see in the practice.
Yes, I agree. And many a times they will improve on their own. So waiting, patching one eye, and sixth nerve, you can even give a Botox. So all these conservative managements often help. I have not, in my almost 18-20 years of practice, done a surgery on a patient with a diabetic sixth nerve palsy.
Right.
They all resolve. They recur. Once it will be the right eye. After 2 years, they'll come back with the left eye. They will recur, but they do resolve.
Okay. Any question for the postgraduates? Dr. Vivek, Dr. Shalu, Dr. Prachi?
I think the postgraduates are much wiser after this talk by Dr. Manjushri. It was a really a very nice talk, easily explained. You very easily explained things.
Thank you so much.
especially the fourth nerve. It was a good idea to take it first.
Yeah, it's always the more challenging nerve.
Yeah.
Ma'am, one more thing. In every six-nerve palsy, the diplopia, can patient come without complaining diplopia? It is
Yes,
more
so
for distance, right?
So, so again, as we said, if it is a multiple cranial nerve, if you're thinking of orbital apex lesions, if there is vision involvement, they will not have diplopia because the vision is so
Yes.
poor.
Yeah.
But if they have good vision in both eyes, definitely patient will have diplopia.
Okay, in isolated cases, mostly the patient has diplopia.
Yes, yes.
Yes.
So I think if there are no questions, we can close up.
Yes,
So
sir, yes.
let me offer the thanks to our speakers, and so it's a really pleasure to have you, Dr. Manjusri, with us and explain nicely all the three cranial nerves in a nutshell.
Thank you.
And of course, I think our postgraduates definitely learned a lot, and we also clinicians also have learned a lot from this talk. Thank you very much for joining with us, and maybe in future again we'll be calling you once again to give some other topic.
Sure.
Thanks, Dr. Nilpna. Thank you for moderating the session today, and Dr. Anita, Dr. Rutyani, Dr. Nazneen, and our panelists. Dr. Tirthajit also is there. Dr. Tarun Pada was also there, our panelists. So thank you very much for joining with us. And last but not the least, the postgraduate students. And of course, I always insist them to come with the video on, but sometimes somewhat they want to remain behind the screen only, because it's face to face. It will be very interesting to talk to the speaker and panelist. But however, it's an interesting discussion. Thanks, Dr. Ajit Babu, our mentor, selecting the topic and selecting the speaker. Once again, thank everybody. Now let us go and enjoy the cricket match going on. And last session is there. So thank you very much.
So I
And
finished in time.
see you next week once again with our other programs. Thank you. Thank you.
Thank
Bye.
you so much, everyone.
Thank you so much,
Bye-bye and
everyone.
good night.
Thank you.
And good night.
Thank you,
Bye-bye.
Manju, for accepting.
Thank you so much, Dr.
Yes.
Thank you. Thank
Bye,
you,
Nilutpar.
Dr.
Thank you.
Sanjay. Yeah, bye.
Thank you.
Bye,
Good night.
everyone.
Jennifer, madam, are you there? I think no.